Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we discuss the impact of the new interoperability rules on health information exchanges. Hello and welcome to our special series on interoperability. I'm your host, Nivedita Patel. I'm an attorney in Epstein Becker Green's Healthcare and Life Sciences practice, based out of our DC office. Health information exchanges have been a part of the healthcare data ecosystem for over 20 years. They have been at the forefront of interoperability as they allow healthcare providers and patients to securely access and share a patient's medical information electronically. ONC's recent final rule on interoperability and information blocking has imposed new regulations and requirements on HIEs and other actors. How are HIEs responding to these new regulations in a space they have been in for decades? On today's show, we're going to talk about the role of HIEs in the interoperability landscape and the impact of the information blocking rules on HIEs. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. I want to hand things over now to my colleague, Alan Kilworth, a member of the firm in Epstein Becker Green's Columbus office. Alan helps hospitals and healthcare facilities navigate a wide range of federal and state regulatory issues, including those related to health information and data exchange.
Great. Thanks, Nivedita. This is a pleasure to participate in this podcast, and I'm excited to be speaking today with Dan Paoletti, who I've known for more than 10 years. Dan has been the CEO of the Ohio Health Information Partnership since September 2011. He has over 25 years experience in health IT, and this background has created a collaborative environment in Ohio, bringing over 150 hospitals, 400 long-term and post-acute care facilities, and thousands of physicians onto the exchange that is operated by the Ohio Health Information Partnership, CliniSync. Welcome, Dan. Thank you for joining us.
Thank you, Alan. It's a pleasure. I'm really happy to be here today.
Great. And even though I gave a little bit of a background about the Health Information Exchange, CliniSync, perhaps you can give us just a little bit more information so we have some information about that organization and the work you do.
Thanks, Alan. The Ohio Health Information Partnership, as you mentioned, which operates CliniSync, is a statewide health information exchange. We are a 501c3 nonprofit organization, a stakeholder-driven organization. Our stakeholders are comprised of hospitals, health systems, providers across the continuum, health plans, and community service organizations. Those stakeholders really guide us in the work that we do. They fund our work and really support everything that we're going to talk about here today as well. Our primary role over the last 10 years, again, has really been to assist providers in adopting electronic medical records and creating a network that allows information to follow the patients. And I would like to add, over the last couple of years, our stakeholders have expanded our mission to include working to address health disparities and equity in the states, using some of the experience and success that Ohio's had with interoperability over the years.
Great, thanks. The subject of interoperability is a broad one. We will get into some more of the details as we go throughout the podcast. But just generally to start us off, what is the role, or where does the Health Information Exchange organization fit within the role of interoperability generally?
That's a really interesting question, Alan. And I would like to say that health information exchanges are different and a little different in every state. And so they each perform the core function of promoting interoperability, but also is driven by both, who operates the Health Information Exchange, who funds it, and who guides it in its work. In Ohio, our role has really been to assist and promote the movement of data so it's available for care and treatment when needed. And over the years, we have really been fortunate because the stakeholders, the hospitals, the health systems, the providers across the state have really been out in the forefront of interoperability in the country. And Ohio has quietly become one of the more interoperable states in the country. And so they really put us in a very good position to be able to deal with these new rules that came out of the Cures Act.
And I think what a lot of people think of health information exchange, just very basically, would be if I'm a patient and I go to 4 or 5 different physicians or a hospital, and all of those providers would have information that went to a centralized database, and any of those providers could then see all of the information. That seems like one of the basic, goals or premises of a health information exchange. Are we there yet? Is that workable right now?
I think interoperability has come a long way, and I'll try to address just a few of the points that you made. A simple way to think about information exchange is really we're trying to replace faxing, paper, and other media that a patient might carry, and really make it easier for the patient to access information, make it easier for the providers trying to care for that patient to access it in a safe and secure and trusted fashion. The idea that all the data has to exist in one space isn't really the case anymore, because health information exchange exists in many different forms. You take the noun health information exchange, which is what CliniSync is. We will help facilitate that information flow and in similar ways that you referenced, but there's also national networks like the eHealth Exchange, Care Equality, Commonwealth, there's EMR promoted information exchanges, and trying to get all of those efforts to work together is really, we have been trying to promote over the years, and we think is really key to promoting interoperability and complying with the new rules. So we are there. There's still work to do, but you have to realize where we've come over the last 10 years. When the HITECH Act was introduced in 2009, still a vast majority of providers had not adopted electronic medical records. And where we are today is 90% of the providers in the country are using an EMR. And now, making sure that all of that information is interoperable, I think the country has done a good job of promoting those standards. And now we have to focus on additional standards like content and definitions and normalization. So there's still work to do, but the country has come a very long way. And in Ohio, we're in very good shape with that.
And in many ways, health information exchange organizations, the whole purpose is interoperability. That's the mission, and that's the service that's intended to be provided. For example, when the CMS interoperability rule, in that rule, there was a requirement added that hospitals send electronic notification to primary care providers and post-acute providers regarding a common patient's admission, discharge, or transfer. And CliniSync was already doing that. And maybe you can explain how CliniSync has helped and how a health information exchange can help facilitate that kind of requirement.
There are many types of information exchange. And as you mentioned, notifications. So when a patient shows up in the emergency room, making sure that primary care physician that cares for that patient is notified saying, hey, your patient's here, they showed up, they've been discharged, here's kind of a summary of the care, please follow up with them. Those are things that have been in place for a number of years here with CliniSync, and hospitals and health systems have really worked hard to facilitate that. So again, as the new COP rules were rolled out last year, again, most of the hospitals were in pretty good shape here. And the EMR companies have done a good job of also enabling notifications such as that. But if you think of other types of information that needs to be exchanged, when your primary care physician orders a lab test, that lab has to go out to an outside lab, making sure that information can come discreetly back into the primary care's physician and be filed under the patient chart. So the physician and staff are notified when the results available, and then can in turn notify the patient that the results are available. As I mentioned, making sure that the primary care physician has a summary of care of an emergency room event, following those ADT notifications, making sure that the ER staff can access critical information on the patient that shows up in the emergency room, especially if that patient is being cared for by a provider that's on a different EMR. All of those are really important pieces of information flow and important for care of the patient. That happens today. There are millions and millions of transactions that occur every day, making sure that providers have the information they need to care for the patients. It's not perfect, and there are some white spaces across the country. And that's partly what some of the Cures Act was intended to solve. Again, fortunately in Ohio, we're in a very good situation because, again, the hospitals and health systems have really driven that over the last 10 years.
Yeah, and you mentioned the Cures Act, and one of the reasons for this podcast is to talk about those rules. The ONC, Office of National Coordinator, has largely driven this push, starting way back in 2004 with the executive order signed by George W. Bush, which itself, that executive order talked about interoperability. It's been the goal for a long time. I think, there is good reason to give some credit to the federal government in this area for pushing innovation and development. I mean, do you think we would be here without some of those activities?
Wow. So I do believe that there are several efforts that the federal government have initiated that have helped promote this work. And, again, as you mentioned, it goes back to HIPAA, to the HITECH Act. HIPAA really does lay the groundwork for exchanging information to help care for the patient. The HITECH Act made funding available for primary care providers to adopt EMRs and also funded the infrastructure in many parts of the country for that data to be exchanged. And as you mentioned, the Cures Act lays out additional structure and guidance and law to promote interoperability. I think they have done a lot to help promote it. I also think that the real heavy lift has come at the grassroots level. The providers and the hospitals and the health systems and the technology companies that are responsible for implementing all of this. That's really where the hard work exists, and a lot of money, time, and effort has been spent to do that. We'll look back on this time in 10 or 15 years and say, yeah, there was probably some better ways to do things, maybe some different ways that we could have promoted things a little bit quicker. But I think, again, right now, everybody's working very hard to make all this happen.
And part of those laws and the sort of the flip side of the promoting interoperability in the form of regulatory oversight that we see with the information blocking rules, where there's sort of a punitive side of it as well. There are new rules and penalties associated with those rules, for interfering with information exchange. That is a different, sort of a carrot and a stick, and that's a different philosophy. You mentioned the grassroots efforts, and in the introduction mentioned the significant role that providers played in the formation, of CliniSync. Do we think the flip side, where we're forcing folks to comply, will be as successful as the efforts that we've had where we've tried to have this be a voluntary effort?
Yeah, so there's a fine line there. Providers and hospitals and healthcare systems, there's a lot of burden with requirements that have been placed on them for many, many years, and adding additional burdens, again, there's a fine line, especially when you throw in complicating factors like the pandemic and all the requirements that came with that, and the strain and the stress that the healthcare system was put under. I think there is fundamentally the desire to make interoperability as efficient and seamless and cost-effective as possible. There has been a tremendous amount of work at the grassroots level with EMR companies, with technology companies, with health information exchanges, with efforts like the Direct Trust and the Sequoia projects and, Care Equality, eHealth Exchange, Commonwealth, health information exchanges across the country. And there's a lot of information being exchanged today. I think the challenge is trying to figure out how to get all those efforts to work together as efficiently as possible, at the same time filling in the white spaces. So there are regions in the country that have not been able to benefit from some of these efforts as much as others. And in part, I believe what the Cures Act was trying to do was fill in those white spaces. So again, it's a fine line of making sure you don't hurt the success that has occurred while trying to bring, again, those areas of the country that have struggled slightly. So again, I think what's important is everybody's trying to do the right thing here, and everybody's trying to make information available as it's needed for care and treatment and care coordination of the patient. And again, we're lucky in Ohio because the stakeholders have really believed in that for years. So I believe we're kind of out in the forefront of this. And as a health information exchange, we are an actor under the information blocking rules now. We feel we are in really good shape and have been complying with the law before it was even a law.
That's the other piece of the information blocking rules, which is that they do apply to a broader set of organizations than just the covered entities under HIPAA. And as you mentioned, your organization and every health information exchange is an actor under the information blocking rules. As you just mentioned, you were already engaged in those activities prior to the information blocking rules, but have the rules or compliance with the rules changed how you're operating or created any barriers or difficulties?
So not really difficulties or barriers. It was really, as the rules were coming out and being finalized, understanding, legally what we were responsible for and how to comply with that and how that interacted with our data governance policies and processes, because we are not a covered entity. We're a VA to thousands of covered entities. So there are data governance policies that are in place to ensure this trust of the network and the data is used accordingly. And then how technology that is in place, fits in with all of those that I talked about here just a minute ago and can enable the promotion of additional interoperability and data standards. And as new standards come out, how we keep up with that. And then ultimately patient privacy, making sure all that works together and understanding what our role is in that function, but also how we can help, some of our stakeholders that might struggle with compliance on their own because they might be an independent provider, a small practice that, also has to comply. What can we do to make sure that we're helping them comply with these new rules? So all that was part of the process in trying to get to where we are today. Again, it was a lot of effort, going through all of that. But at the end of the day, we were fortunate because we had a head start, again, just because where our stakeholders had pushed us to get to.
And you've mentioned EMR and EHR vendors in some of your comments. I think maybe some folks view HIEs from the outside as connecting providers, physician to physician. But a lot of times you're working directly with EMR vendors and you're connecting EMRs. You're connecting the systems, the medical record systems that are owned and used by physicians. Can you talk about a little bit about that and how you interact with EMR vendors and technology in general?
Yeah. So, again, as I mentioned, it's really important to try to understand what role as a health information exchange that we should fill and how best to help our stakeholders. There are lots of technology and new standards being developed there. So our role is ever changing. There are national networks in place, like as I mentioned, the eHealth Exchange, Care Equality, Commonwealth, the Patient Centered Data Home, which is a large effort among Health Information Exchange promoted by Civitas, which is the National Organization of Information Exchanges, where we best complement all those efforts to make sure we're not duplicating efforts, we're not duplicating cost and infrastructure, and really promoting the best we can the standards that are rolling out. Again, it's not necessarily the most exciting thing that we do, but as I mentioned, results delivery, pushing a lab result from the lab into an EMR and under a patient's chart. That's not what you typically think of when it comes to health information exchange, but it's incredibly valuable making sure that, again, that primary care doctor has that data discreetly in the patient chart. So their EMR can maximize the functionality and indicate, follow-up that might be needed and so forth. So again, there's lots of different types of exchange that we look at in really trying to focus on, where we're needed to fill in those gaps. And I think that's one of the biggest challenges when you look at health information exchanges as now and moving forward. What is our role? Where can we bring the most value to the stakeholders and to the state? And really making sure we're ready to fill that role.
We've talked a lot about some of the fundamentals of exchange services that are provided and how that works a little bit. You mentioned earlier in your comments, health equity. As we look forward at health information exchange, do we think we'll see a broader set of participants so that there will be, more than just doctor to doctor, that we'll see folks participating in health information exchange really for social services and for other non-traditional, just pure office visit type of lab result type of information?
I believe that that's a critical part. There are a couple of things. I think with the pandemic, one of the things the pandemic showed us is that there are many, many different entities that need to come together in kind of a public-private partnership to better facilitate the information needed for public health, and then extending that into support for health disparities and equity that is in place in every part of this country. Taking what we've learned from an interoperability perspective over the years around clinical to clinical data exchange and leveraging that to help facilitate better public health data exchange and social service support for these vulnerable communities, I think is absolutely a critical role that we can help fill and put in place. I think there's still a lot of understanding exactly what role health information exchange might play in those areas. But again, I think that is a key role that we are definitely looking at for the future. And again, one thing to consider is technology advances, which it will, as standards advance, making interoperability easier. We still need to make progress on content standards and definition standards and normalization standards to make all this easier. But if we fast forward 3, 5, 7 years with the onset of new standards like FHIR and 360X and APIs, interoperability is going to become easier. It is going to be great for, advancing care and efficiency. So again, understanding what role the health information exchange plays in that space is, really what we're focusing on now.
Speaking of, the recipients and participants in health information exchange, do you think we'll ever see patient involvement, patient participation for patient access to health information exchange?
I'm sure you will. I believe there are health information exchanges out there that do have patient access capabilities. In our instance, we work to make the information available directly to the caregivers, and then the caregivers all have patient access capabilities through their EMRs. So there are different ways to manage that, but I do think patient involvement is important. I think we've looked over the last 5 years, with the push of patient access through APIs to EMRs and getting the patient more involved is really been a focus. Again, where all that goes, I wish I could tell you. Again, I think something else the pandemic has shown us is that telehealth and remote monitoring are important tools that will become even bigger as we move into the future, and how that information also is made available to different providers as they're trying to care for the patient. There's a lot of things that are constantly changing, and we have to make sure we include in the idea of interoperability and exchange. So the patient is going to play an important role. Absolutely.
Yeah, there's so much, health data. I think when people think of like a personal health record that a patient can access, they're really thinking of a portal, as you said, that a physician or a hospital might have, where the patient can go in and see, summary information. But there's a voluminous amount of information that travels behind that. I think one of the competing interests is, how much of that patients should certainly have the ability to get all the information about themselves as they want. But if you push too much information to a personal health record or to a portal, it would be a little bit overwhelming for someone to have, and not necessarily easily digestible for a patient.
I'll just expand on that for a minute. I think what's important in what you just said, it's access to not just the patients, but to the providers that are trying to use information. So when we look at interoperability, again, I think we've done a really good job in the country of making information available, but we also have to make it actionable. And it's not necessarily realistic for a provider trying to sort through 10 different sets of documents because that all came back to them when they made a query on the patient. So, making sure that it's efficient for the provider and the staff, and the patient to go through the information, present the relevant information to make sure it's actionable, again, is all part of the context and the standards. Again, there are new standards like US CDI that are going to be in place and are in place that will make it easier. But again, as we move more towards those, again, content and data definitions with a focus on making the data actionable, I think is really an important thing to keep in mind, because volume isn't necessarily good. You got to focus down on what's important.
We may have hit some of them already in some of the conversation, but I wanted to ask, where you think challenges to interoperability exist, particularly for health information exchange. What are some of the challenges that remain in achieving interoperability?
There are still, specific state laws that make it challenging to move data across states, restrictions around Part 2 data. Again, for some of the most vulnerable populations, it's difficult to make sure that the information gets where it needs to be the concept of minimum necessary. Again, making sure that providers are responsible for providing what's necessary to accomplish the goal when exchanging information. And so that idea of making that a little bit about what we talked about earlier, the important information available when necessary and not just volume is also a challenge. Patient privacy and consent and security, making sure that as we move forward with interoperability, that we keep up with technology and ensure that it's secure and done in the right way. And making sure you're bringing the data together around the right patient. Again, patient matching continues to be a challenge, and making sure that the information is being brought together in the right way is all, I think, challenges that aren't going to go away. It's just figuring out the best way to manage them.
At a basic level, do you see providers reluctant to participate in exchange, or are the bigger problems, as you mentioned, compliance with a complicated set of state and federal laws that some of these providers have to navigate to get to the point where they can participate in exchange?
I'll caveat this as I can really only speak to what we see in Ohio, and we do not see in Ohio providers hesitant to participate in information exchange. For years, again, Ohio's been on the forefront, and the providers and hospitals and health systems have been championing the effort to make sure the information gets to where it needs to go. It's really been around making sure that the different systems can talk to each other, which we've made large strides with, as we've talked about with interoperability, ensuring the smaller providers, that last mile, the independent physicians have easy onboarding access to information exchange. The providers that were left out of meaningful use, so the post-acute care facilities, the behavioral health, home health care, so they were never part of those meaningful use efforts to promote EMR adoption. There's still some financial pressures. There's lots of financial pressures on those types on all healthcare providers, but really trying to add the addition of adopting technology that can be interoperable is still something we're trying to make headway in the country with some of these other types of providers in the continuum. But we're making great progress. I think right now the focus needs to be on addressing some of those challenges that we talked about, really focusing on adoption of additional standards and data definitions and content definitions, and expanding into the social service area to make sure that all the work that's going on and referrals around social service support also is interoperable too. So those are my thoughts.
It's an interesting answer. It really is. You see the information blocking rule title, and you think the only issue is people blocking information from each other, but it's a complex issue, obviously, with a lot more tentacles, as you just outlined. My last question that I'll ask is to maybe look into the crystal ball. 5-10 years from now, where do we see interoperability, and where do we see health information exchange as part of that?
Yeah, I wish I had that crystal ball and I could give you the exact answer. But I think the good news is, we have made great progress in the last 10 years. We have the new FHIR standards, APIs, 360X, national networks, all in place and broadening, adoption of these standards and the addition of new aspects of all these standards. So I think interoperability is going to continue to become easier. The role of a health information exchange, as I explained a little bit earlier, I think is going to be different a little bit in each state. Here in Ohio, expanding our mission into, attempting to move health disparities and equity in the state, I think is going to be a key functionality. And some of the current work we're doing in moving data may not be needed in 10 years. So again, how do we continue to bring value not only to the stakeholders, but in the communities that we serve, I think is something we're all trying to figure out right now. The only thing I can tell you is in 10 years, it is going to be easier. And there's going to continue to be new technology to promote this and making sure it's done in a safe and secure way. So it's an exciting time.
Thanks, Dan and Alan. This has been a really good conversation to hear about the HIE perspective on interoperability. As a closing question to you, Dan, as you mentioned earlier, CliniSync and other HIEs have been complying with these new laws and regulations before they were even law. What advice would you have for other entities that are now faced with adapting to the new regulations, whether they're actors that are new to this space or other types of entities?
The first piece of advice I can say is make sure that from a legal perspective and compliance perspective, you have the policies in place to manage the requests and requirements that you're going to be held to. And that's really a great place to start. And then trying to understand where your technology gaps are to be in compliance. Again, I think health information exchanges and networks, because it's not just health information exchanges, it's also other networks that have to be in compliance here, making sure that they're open to participants as they want to come on and join and be part of the effort. That's also important to try to take a look at the ability to bring on and make information available to these networks that need to interact. So again, a great place to start would be, again, compliance and legal and understanding what you're actually responsible for.
Dan and Alan, thank you again so much for joining the show today. It was a pleasure having both of you.
Thank you very much. It's been a pleasure.
Thank you. It was a good conversation to have. And again, thanks, Dan.
I would also like to thank the audience for listening to our special podcast series on interoperability. If you like what you hear today, please subscribe to the show. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.